Thank you, Rina. We are a little bit behind schedule, but we will do our best. The next session will be entertaining, I hope. And I would like to call the expert panel. We are going to discuss patients, so I would like to call Dr. Jane Churpek from the University of Wisconsin-Madison, Dr. Yasushi Miyazaki from the University of Nagasaki, Japan, and Dr. Lou Silverman from Mount Sinai, New York. Top expert people, and the first patient will be presented by Dr. Howard Oster from Tel Aviv. Howie?
Thank you, Moshe. Thank you, everybody. I'm very glad to be here. Good morning. I'd like to present our patient who had familial myeloproliferative neoplasm, acute leukemia, and Langerhans cell histiocytosis. It's a story that will start from 2021, but it actually goes way back. How do I?
Push the green button.
No, not the mouse.
Okay. So we'll start with our index patient, PA, from January of 2021, where he presented with high-risk myelodysplastic syndromes, but he had pre-existing hematologic disease and other diseases as well. Now, I'd like to take us back further in time, not just from his history, but his family history as well. In 2004, his father, B.A., presented to our hospital with acute pneumonia. He actually died of that pneumonia during that hospitalization, and he was found to have an undiagnosed acute myeloid leukemia. Now, the brother of our index patient presented in 2006. He was then 37 years old, and he had polycythemia and thrombocytopenia. And our index patient presented in 2013. That was his first presentation. He was then 40 years old, also with polycythemia and thrombocytopenia. And if we go further back in history, it turns out that the brother's paternal grandmother had thrombocytopenia and some sort of bleeding disorder, but we don't know anything more about it. And 3 other family members also had hematologic diseases, at least one of whom had AML. So for the 2 brothers, MA and PA, they each underwent evaluation for the possibility of MPN, and the classic genetic workup, JAK2, CALR, CMPL, ABL-BCR, all of these were sent and came back negative. So the next step was sending them for next-generation sequencing, evaluating for 54 myeloid genes, and all of these were negative as well. So we went the next step, doing whole exome sequencing, and we found, interestingly, a mutation in the ANKRD26 gene. Now, of course, I knew everything about that gene, but in all seriousness, looking at this more carefully, and for our audience, let me just say a few words about the ANKRD26 mutation. Now, this gene is found on chromosome 10 and is important for platelet production, and the mutation or mutations are found in the 5' untranslated region of that gene, chromosome 10. It's associated with familial thrombocytopenia, THC2, and it can be associated with possible hematologic complications, including polycythemia, bleeding, although major bleeding is rare. It has association with various leukemias and can have other bone marrow disease, including MDS. So our 2 patients, MA and PA, had been treated for their MPN, blood phlebotomy. They underwent genetic counseling. And where things became more interesting, let's go back to January of 2021, where PA, our index patient, appeared at the dermatologic clinic, and he had a perianal lesion, and he also had some skin lesions, and biopsies of these lesions showed Langerhans cell histiocytosis with a BRAF positive profile. Coming back to the hematologic clinic and taking a history, he was found to have headaches, polyuria. He had a very significant weight loss. He had low urine osmolarity, and he was diagnosed with diabetes insipidus, which can be associated with LCH. He also had an MRI, which showed various bone changes. And both the skin and the perianal lesion, as I said, have BRAF positive. Now, because LCH can be affiliated with bone marrow disease, and because this patient also had hematologic disease beforehand, he had a bone marrow evaluation, and it was normal. There was no sign of LCH in his bone marrow. So PA underwent treatment with DDAVP for his diabetes insipidus. That was successful. He had cytarabine. And after 5 months, he had significant improvement. But after 11 months, he had a relapse, both in the skin and in the perianal region. And biopsies of these areas showed identical pathology. Then he started having changes in his bone, in his cellular counts. He still had the same thrombocytopenia, but he started having anemia. And at this point, a repeat bone marrow demonstrated dysplasia with 9% blasts. Cytogenetic evaluation was normal, but for the diagnosis of myelodysplastic syndromes, he was treated both with azacitidine and venetoclax, and he achieved complete remission. His platelets had always been low, actually normalized, and what was most interesting is the skin, and especially the perianal lesion, resolved. So we have some questions for our panel. Number one, we have these two diseases, LCH and the familial thrombocytopenia with the ANKRD26 mutation. We think that these could be related, and the question is, do you think that they're related? Are these diseases related to MDS? And perhaps most importantly, where do we go for now? How do we treat PA? He's currently in complete remission. Is there an indication for BRAF inhibitors? Should we have treated him with those earlier? And especially, should we treat him with those now? And where do we go from here in general? Transplant, all the possibilities. Thank you very much.
Great. So with the time limits, we are going to try to stay on time, so we're allowed to have one short comment each about the case. So I think from my perspective in this situation, there are really two key lessons. Number one, I think the threshold for diagnosing myeloid diseases in these patients with germline mutations, especially this disorder, really has to be high. So these patients can have baseline erythrocytosis because there's excess TPO signaling in these patients at baseline. And so, and they also in their bone marrow have some abnormal appearing megakaryocytes. So usually it's unilineage megakaryocytic dysplasia, but there are very nice reports of misdiagnosis of MDS. So I would be careful about the diagnosis of myeloproliferative neoplasm at baseline in this patient if there were not the characteristic mutations or bone marrow morphology, and also be careful about the MDS. Probably not when they already have 9% blasts, but I would be interested to know what MDS mutations are there. And then LCH is considered in the myeloid spectrum, so I think there could be an association, and the BRAF inhibitors are a really interesting concept. I would have been very interested to understand what happened to the platelet count in this patient with using a BRAF inhibitor or cobimetinib, other inhibitors of the MAPK pathway. Because in vitro, these patients' megakaryocytes have been shown to improve platelet production with those inhibitors in vitro. So I think that would have been interesting in this specific patient.
Professor Miyazaki?
Okay. First of all, I'm very surprised to see this family pedigree. We understand that how ANKLD26 mutation can cause many different kinds of hematological malignancies, mainly myeloid, but some lymphoid. That's my first impression. In terms of this treatment for this particular PA patient, I think, again, the mutational check of ANKLD26 is very important. Although platelet count is normalized after azacitidine plus venetoclax treatment, we do not think that the mutated clone completely eradicated because this is a hereditary disease. So we have to check this first, and then if it exists, I think it is highly possible transplantation will be the next step for this patient, considering very high penetration of this family pedigree.
Lou?
So I agree with both my colleagues that this is a highly unusual case, and it offers some kind of insightful, is informative in terms of pathophysiology and potentially mechanism. Both the THC2 and the LCH have at least the potential for a common pathway in increasing activity of MAPK pathway. So in the TCH2, ERK has been upregulated as a consequence of the mutation, and in LCH, with the BRAF mutation, and MAPK is also upregulated, and thus potential inhibitors such as BRAF inhibitors are potentially useful. There are other data about activation of MAPK, both specifically and non-specifically, that may lead to MDS, and that may be the linkage here, although it's hard to draw a definitive line between these two entities and MDS, other than the fact that the literature shows that there is an increased incidence of MDS in these patients. You may have identified a new alternative therapy for at least LCH with the use of azacitidine and venetoclax, which would be interesting. And I agree with you that transplant, given his age and his persistence of mutations, is likely the potential next step for this patient.
I hoped you would say no transplant, but you're making my life much more complicated. Thank you.